So I want to start a little bit more general. So clearly CRRT is something we do every day, and at the same time, we've already heard it involves so many different aspects. And in our clinical practice, we already know that many different people are involved, that it requires regular monitoring, and things can go wrong sometimes. I strongly believe that all of us come to work and we want to do a good job. We want to do the best we can, and we want to give the best therapy and care to the patient in front of us. And we want to meet the attributes of high quality care. And there are 6 attributes. One is safety. So all of us clearly want to avoid injuries and put the patient at harm. We want to deliver safe care. We want to deliver effective care and avoid over and underuse. When patients need treatment, we want to deliver it with high quality. We strive to provide patient-centered care so that the patient at the end benefits and has an improved outcome, whatever their perceived desire and wish is. We want to deliver our care in a timely manner and reduce waste and delays. And clearly we want it to be efficient. Whatever we do, it needs to be efficient. And we all, I strongly believe, want to deliver equitable care, where patients who need a particular care or treatment get it, independent of other circumstances. Now, at the same time, although we have this desire, and we strongly strive to do so, we have to recognize sometimes mistakes are made, sometimes things happen, and they're out of our control. And it is alarming that medical errors occur, and it is very alarming and upsetting when some of the medical errors lead to patient death. And patients come to harm. And if you look at some of these reports in the literature, then clearly preventable medical errors do occur. And patients have died unnecessarily, and healthcare costs have or healthcare finances have been wasted unnecessarily. If you look at quality of care across the world, then again, it's very clear there are differences between, sometimes within departments, between institutions, and differences between countries. And in audits, where auditors looked at healthcare in general, they noted that even highly qualified clinicians, healthcare givers, fail to deliver on all of these 6 domains with regards to quality care. So this brings us to quality of care, which is, I think, ultimately our aim when we talk about documenting and preventing complications. I'm sure you would all agree that quality adds value, and when we really look, then we always find something that could be improved. But if we want to judge how good we're doing and how well our care is and our delivery of care, then we need to know our own data. Knowing where you stand, how you're performing is essential to judge whether the care is of high quality. And knowing the data allows analysis, reflection, and education to improve care. Now if you then use these concepts and thoughts and just go back to CRRT or RRT. So I think ideal renal replacement therapy would be provided to the patient who needs it at the time when they need it, be delivered by highly trained, skilled people so that the patient then has their extra and intravascular volume controlled, has an effective correction of the acid-base disturbance, has complications of acute kidney injury corrected, effectively clears toxins, and has a reliable, predictable clearance of drugs, so that the prescription of all various renal drugs is optimal. But renal replacement therapy is delivered as long as necessary without without compromising renal recovery and without putting the patient at risk of complications. And so that ultimately, after this session of renal replacement therapy, the patient has a positive experience, leaves hospital alive, and has not had any potential negative consequences of having received renal replacement therapy. And that's what we strive to do. In reality, it's extremely difficult to do this because CRRT is such a complex therapy. We've already talked about some of the different aspects and the catheters and the length and the circuit and the clots and the anticoagulation and so forth. There's so many people involved in getting it right. And in the center of all of this, we have a patient. And obviously, the interactions and the delivery of CRRT depends on a close teamwork between all these players. And just having one not performing well or not being available can cause significant interruption in the therapy. So then, how do you avoid complications? How do you avoid delivering less than optimal or less than high quality care? And that brings me back to that's where we need to know our own data and reflect on our own performance and reflect on how the therapy is delivered to the patients. And then I'll put it to you, what aspects of CRRT care do you routinely measure? And I give you a few more questions, but then I invite you to maybe respond. So in your ICU and in your practice, do you routinely look at filter lifespan and know the average filter lifespan? Do you know what the average treatment downtime is? Would you know how long it takes to restart the filter after it's had a period of interruption? Would you actually know what the average delivered dose is per month? And do you know how much fluid gets removed and whether when you start a CRRT, whether you achieve your fluid balance targets? And to my embarrassment, although I'm very fond of CRRT, I like CRRT, it's an area of clinical interest and research, I have to admit that in my practice where I work, we do not routinely look at all these parameters every month and check our own performance. And I would just be interested to see whether you in your practice would do this, whether you have even just one of these parameters as your regular benchmark to assess your performance. Well, I can't see any hands. We do. Oh, okay. Professor Mehta, excellent. Yeah, fantastic. All of them? Most of them. And again, most of them, it brings me to the next part of my talk, because the question then is, if you don't routinely measure any of them at the moment, where do you start? Which parameter, which factor is the most important one to look at? Now, if you want to start looking at your own performance and the quality of care, then people who know much more about quality improvement than me suggest that you should look at different aspects related to the structure, process, and outcome. So structure describes essentially the infrastructure required to deliver a therapy. So that's the machines, the nurses, the equipment, and so forth. The processes of care involve all the various steps needed to deliver the care, for the patient to receive the care. And then the outcomes depend on, obviously, the therapy you're giving, but they should include some safety outcomes, some important patient-centered outcomes, and obviously survival. But if you don't routinely look at any of these factors, and I've already admitted we don't, despite me working in a very large unit with a very high CRRT activity, then you obviously may want to start and pick one or two of these parameters. Now, the literature could help a bit, and Professor Bagshaw and colleagues in Canada have had a strong interest in quality care, high-quality CRRT for a while, and looked at the existing literature. And they identified 133 studies that had looked at quality indicators for potential auditing and quality improvement projects. Now, some of them related to the infrastructure, so the structures required to deliver CRRT. Some refer to processes, and as you can see here, I've listed the various processes that have been used as quality indicators in the literature. And some of the studies looked at outcomes, and again looked at various different outcomes. And this exercise was very, very eye-opening, because first of all, it shows this large spectrum, and clearly you can't start and look at all of these indicators at the same time. But even if you pick one and say, okay, from now on, I will routinely look at filter life, and routinely look at complications. Even then it's slightly difficult, because how do you actually define filter life and performance? Do you look at the filter survival, or would you look at number of unintended interruptions, or do you look at duration of interruptions? Similarly, if you say, I want to look at complications and I'm concerned about bleeding complications, how do you define a bleeding complication? Is it a new bleed, but it's small or large? Is it a bleed which requires a blood transfusion? And so forth. So we have not, at the moment, got consensus on these important potential quality improvement parameters. And this prompted various people, including Professor Mehta and Professor Kashani from the Mayo Clinic, to call a meeting, so a 3-day meeting, to talk about quality care, quality improvement in acute kidney injury and renal replacement therapy. And it was very, very educational, but also highlighted the gaps in knowledge, but also gaps in clinical practice. But the expert team, after a 3-day meeting, came to various conclusions, and the majority is summarized in this paper, which is freely available. But there was absolute consensus that quality indicators are needed, and that quality indicators should integrate indicators related to structure, the various processes, but also importantly outcomes, and that the outcomes needed to include important patient-centered outcomes that were valued by patients. And there was a strong belief that this was necessary to improve quality of CRRT and to improve processes of care. And so this brings me now back to the title which I was given, the importance of documenting and managing and recognizing complications. So clearly, when we make a decision to start renal replacement therapy, or to either intermittent or CRRT, we give our colleagues, and usually the nurses at the bedside or the dialysis nurses, a prescription. And as a minimum, I think a prescription would include these 6 parameters as shown here. And then we usually give the nurses some targets. Targets related to clearance, to dosing, to fluid removal. And at some point in clinical practice, we also look at, on the daily ward round or at the end of the day, to see whether the outcomes have been achieved. Now, we could easily do this routinely every month and see whether our CRRT prescriptions routinely met the targets and achieved the outcomes. And then obviously feed back into our protocols and our prescriptions. And so you can just see how you could, if you choose the right quality indicator, slowly develop a quality improvement project and routinely evaluate these parameters with the intention to improve quality and improve the practice in the department, in the unit, in the institution. And there are data in the literature showing that this can be done successfully. So here we have results of a successful quality improvement project where the team every month looked at various aspects, and it shows important aspects which were relevant to the patients and relevant to their department. So in this case, average filter life, the time before initiating renal replacement therapy after a period of interruption, and the performance related to dosing targets. And as you can see here, over a 12-month period, there were some fluctuations, but there was a trend towards improvement. Now, Professor Nera and colleagues with a strong interest in quality improvement have summarized the importance, but also the essential components of successful quality improvement projects. And clearly you need to be ready for this and be willing to do this, be willing to acknowledge that the quality of care may not meet all the criteria at the moment and that you are trying to improve things. But it can't be done on your own. Nobody can do this. Nobody practices in isolation, so you will need buy-in, or we will all need buy-in from our colleagues and a general commitment and engagement to do so. But even then, we need more because we will need help from technologies, and the good thing is that the CRRT machines, but also digital tools are available to make things easier, to monitor things more easily. And education will be required, in particular in areas where we may find that our performance is not as good as we thought, where we routinely lose filters, where the time to start a new filter is unacceptably long. But if you get all the components together, so the readiness to take this on, the engagement in the team, the right culture to wanting to improve care, supported by techniques, technology, and education, and an education program, then it is possible to achieve better outcomes. And again, I'll just show you an example from the literature where this was done, where the teams looked at different aspects and filter life, delivered dose, delivered versus prescribed dose, and over a 12-month period showed a significant improvement in these different areas. So I want to finish saying that I strongly believe that all of us strive to deliver high-quality care. To do this, we need to understand our data. If we want to understand our data, we have to document them and monitor them and reflect on them, evaluate them, and then with the right support and the culture in the department, institution, we can improve the quality of CRRT, because it's a complex, very complex therapy. But CRRT is a team sport, and it can be done if we all play together. Thank you for your attention.